Welcome back to the next edition of the JASN podcast. I'm Kurella Tamura, Deputy Editor of Clinical Research at JASN. Well, it is virtually impossible to open a news app or scroll through social media without seeing GLP-1 receptor agonists in the headlines. From weight loss to metabolic health to emerging research on addiction and inflammation, these drugs are having a massive cultural and medical moment. But while the public focuses on the headlines, patients with advanced kidney failure and those on maintenance dialysis have watched the cardiovascular benefits of GLP-1s from the sidelines. Today, we're looking at an exciting new study in JASN that finally brings the GLP-1 receptor agonists into the dialysis unit to see if the hype holds up where it matters most, preventing major cardiovascular events in our most vulnerable patients. Joining us to break down the data are Benjamin Catanese and Daniel Edmonston from Duke University. Thank you for joining us. Could you take a few minutes to introduce yourselves and maybe tell us how you got interested in this line of research?
Sure. My name is Ben Catanese. I'm a medical instructor and nephrologist at Duke University. I got interested in this area as getting into research and fellowship and continued to be interested in it as I moved into my faculty role, particularly interested in cardiovascular disease and metabolic disease in patients with chronic kidney disease, and started seeing patients being prescribed these medications and wanted to research it further to better understand how they were doing with it and if they were benefiting.
And I'm Daniel Edmonston. I'm an assistant professor of medicine at Duke and a clinical investigator with the Duke Clinical Research Institute. My research program's really been focused on clinical trials and observational methods, some translational science and implementation science that's been aimed at improving cardiovascular complications of kidney disease and more broadly cardiovascular kidney metabolic health. And so this project that Ben and I have been working on now for some time really sort of born out of that interest where, this is clearly as you mentioned at the beginning, an exploding class of medications with very, very exciting implications across the CKM spectrum. This is an incredibly high-risk population, and so we were pretty excited about the opportunity to investigate this class of medications in that very vulnerable population, as you said.
Well, thanks so much for that introduction. Let's dive right in. So let's start maybe with what's known about these two classes of medications. DPP-4 inhibitors competitively inhibit the dipeptidyl peptidase 4 enzyme, preventing degradation of native GLP-1 and GIP. GLP-1 receptor agonists mimic the action of GLP-1, which leads to continuous activation of the GLP-1 receptors. What is known about the safety and effects of GLP-1 receptor agonists in patients with kidney failure? And, if you want to add DPP-4 inhibitors before your study was launched?
There is some reassuring pharmacokinetic data available for patients with kidney failure that indicates that most GLP-1 receptor agonists are safe for use in this population. It seems that most are not dependent on the kidneys for metabolism. That said, leading up to the study, there's a lack of safety and efficacy data, which was a large reason for why we set out to do this study in the first place. And I think really until 6 months ago, there was little published on the efficacy area. Another group published a study using USRDS data looking at patients with kidney failure that started on GLP-1 receptor agonists, and they did look at safety data. And I know they found that there was an increased association with diabetic retinopathy, but not with other safety outcomes. But beyond that, there is little safety data available for patients with kidney failure. And then as far as efficacy, this previous study did show improved mortality, but prior to our current study, there was not evidence or studies showing efficacy or the effects of GLP-1 receptor agonists as far as cardiovascular disease goes in patients with kidney failure. So I think it was exciting to be able to undertake this project to explore that further.
Yeah, thanks so much. So, like, if in the dialysis unit, the typical way in which we manage glycemic control in the diabetic dialysis population is that insulin and DPP-4 inhibitors with a little bit of sulfonylureas. Can you talk a little bit about that? Like, what's our current standard of care?
I think you captured that accurately. I think our current standard of care is reaching for DPP-4 inhibitors and sulfonylureas along with insulin. I think, though, this was even the standard of care for patients with CKD prior to the RCTs we saw, like Flow, that started investigating GLP-1 receptor agonists in our population with CKD. And now we're reaching for GLP-1 receptor agonists first in those patients with CKD not on dialysis. I think, though, while it's not the same population, we're starting to better understand that we can use different agents in patients with kidney failure. But I think, going back to your question, I think, yes, insulin and DPP-4 inhibitors and sulfonylureas are the current standard of care. I think that we have started seeing more and more providers use GLP-1 receptor agonists in dialysis. And while there is the lack of evidence, I think that was another motivating factor in that, while not part of standard of care, we have seen our fellow nephrologists begin to use these medications more and more.
And to build on that point too, one of the things that we looked at early on in the process of deciding whether or not this was going to be feasible to do this study in the USRDS data set was we did look at the prescription patterns of these anti-glycemic medications, and of course wanted to get a sense for how much providers are prescribing GLP-1 receptor agonists in this population. And you could definitely see I wouldn't necessarily call it an explosion in prescriptions of that, but there was a substantial increase in the number of prescriptions, especially towards the end of our analysis data set, turning the 2019, 2020, definitely 2021 data. There was a substantial increase in the number of prescriptions for GLP-1 receptor agonist. Now, obviously, we can't necessarily infer the indications for their use, and there clearly were other use cases for the GLP-1 receptor agonists, specifically for weight loss, but clearly there was increased use for glycemic control as well.
That is so interesting. I guess I'm not surprised that people are using it off-label in a way because of how exciting these new agents are. Let's turn to the study. You mentioned that you used USRDS data to conduct the study, and I think most of listeners are familiar with USRDS, a national registry in the US of dialysis patients. Let's talk a little bit about study design. So you used a new user active comparator design. Can you tell our listeners a little bit about the rationale for this design? Like, what is it, why use it, and the types of biases it's attempting to mitigate?
Sure. The goal was to simulate a clinical trial as best we could with the data, or with the trial design, in that we were trying to capture patients as they were starting on GLP-1 receptor agonists, and then have an active control group with those being starting on DPP-4 inhibitors. And I think with this trial design, we were attempting to mitigate three main sources of biases, and these include immortal time bias and prevalent user bias, and then confounding by indication. I think the immortal time bias is a particularly important one to highlight. And I think if you imagine that if instead of an active comparator, we compared GLP-1 receptor agonist users to the general dialysis population, there's often weeks or even months between when someone starts dialysis and when they eventually start their GLP-1 receptor agonist. And during this waiting period, by definition, no one in the GLP-1 receptor agonist group can die. And because if they had died, they wouldn't start on the GLP-1 receptor agonist. Meanwhile, patients in the comparison group, if we hadn't used the active comparator, could die in the same window. So then when we're looking at survival data, GLP-1 receptor agonists could have a hidden head start. And so by using the active comparator design, we anchored everyone's follow-up up to this exact same date, and that they were starting on one of the two study medications. And I think that's one of the big benefits of using this active comparator design.
And one thing I'd just add to that too is, using real-world evidence for similar cardiorenal outcome studies in the CKD and then more broadly in the type 2 diabetes population. That's been an active comparator that we've used in some other studies, specifically comparing cardiorenal outcomes for SGLT2 inhibitors, and found that it was a pretty effective active comparator since it, for the most part, has no clear association with cardiovascular or in other populations kidney benefit or harm, which is also important. And they have very similar uptake in terms of use for their uses for anti-glycemic control. A1C lowering effectiveness is similar between the two agents, specifically here talking about GLP-1s and DPP-4 inhibitors, not true for SGLT2 inhibitors, of course. But so we felt like with those aligned and mitigating the risk of biases that have been discussed, it felt like it was the best option. Although there have been other studies that have used other methods of controlling for the immortal time bias and landmark analyses and others, and those are completely valid approaches. But we felt like this was a little bit more of a straightforward way of doing a cleaner target trial emulation.
Yeah, thank you so much for explaining that. So let's turn to your results. Could you tell us a little bit about how many patients you studied and what you found?
Sure. So the matched cohorts were approximately 3,000 in each of the arms in the GLP-1 receptor agonist initiators and the DPP-4 inhibitor initiators. And I think the headline finding, it was exciting to see that GLP-1 receptor agonist initiation was associated with a 13% lower risk of our modified major adverse cardiovascular events outcome compared to DPP-4 inhibitors, and also is associated with a 17% lower risk of this modified MACE outcome in the sulfonylurea group. I think on top of that too, the mortality risk reduction was interesting to see as well, that GLP-1 receptor agonists were associated with 17% reduction in all-cause mortality. And I think it was really interesting to see that this data was consistent with previous studies involving patients with chronic kidney disease, like the FLOW trial. I think oftentimes with patients with kidney failure, we don't see the same cardiovascular benefits that we see in patients with CKD, but not on dialysis, or the general population. So I think this continuation of this benefit within this population is a really notable result and an encouraging result to see that patients with kidney failure are benefiting as well from GLP-1 receptor agonists.
And to build on what Ben was saying about the outcomes as well, I think one thing that's important to note is that for the composite MACE endpoint, we included all-cause mortality rather than an adjudicated cardiovascular mortality. And we were encouraged to see that the reduction, the association with the lower risk of MACE was definitely on par with what was demonstrated in analogous data, especially trial data in the CKD population, which was FLOW, as well as the mortality estimate itself being consistent, and knowing that these medications in other populations, specifically CKD, have such a substantial reduction in cardiovascular mortality and all-cause mortality. We felt pretty strongly that that signal would have been consistent if the MACE composite were restricted to an adjudicated cardiovascular mortality.
Yeah, thanks for pointing that out. So the USRDS doesn't really have the ability to identify cause-specific mortality. So that seems like a really important point. Was there anything in the results that surprised you?
I think in a way that it was consistent with previous studies involving patients with CKD. That was surprising. Our hypothesis was that there would be a benefit, but I think given that we've seen other medications not show a reduction in adverse cardiovascular events in patients with kidney failure, that there was a good chance that there could have not been a benefit with initiation of GLP-1 receptor agonists. So I think in that way, that was surprising. I think also that we saw the 10% reduction in heart failure hospitalizations in the GLP-1 receptor agonist initiators compared to DPP-4 inhibitor initiators was a surprising outcome. I think anytime patients are losing weight with medications, especially patients requiring dialysis, it starts to become complicated adjusting dry weights and accounting for weight loss beyond changes in fluid shifts. So I think that was an outcome. There's plenty to unpack with that. And I think it's complicated to look at heart failure hospitalizations for many reasons. But I think the fact that we did start to see a signal there was encouraging as well, considering what complications that can arise with losing weight with medications and patients requiring dialysis.
Yeah, Ben, the point about the heart failure hospitalization is a big one. You bring up two components of that I think are important to understand. The first one, which I think is least important, so I'll discuss it first, is, I would say why this would qualify somewhat as surprising is that adjudicating heart failure hospitalizations in the dialysis population within the context of a clinical trial where you have a dedicated dossier looking at all of the information that you need and you're manually adjudicating it, even in that optimal scenario, it's very challenging to accurately adjudicate heart failure hospitalization in this population, just because volume overload from missed dialysis treatments will look virtually the same. And we knew that looking at claims-based heart failure hospitalization was going to be therefore a challenge. And our expectation for showing any sort of heart failure separation was pretty low. The FLOW trial did show, at least to me, an encouraging and surprisingly reduction in heart failure hospitalizations in the CKD, in the FLOW trial, which was a CKD cohort, of course. Seeing the reduction in heart failure hospitalizations here does make sense and is consistent with that. Although, I would say the exact magnitude of that in the context of the clinical trial would likely be different. I think the more important point that you alluded to is important to understand with GLP-1 receptor agonists in this population, and that is when you have a medication that can, especially at weight loss doses, but even at glycemic control doses, lead to pretty rapid and substantial weight loss. When we are evaluating our patients receiving, especially maintenance in-center hemodialysis, with the frequency that we typically reassess their target weight, they could be losing lots of actual lean mass in between that. And if we are not adjusting the target weight to reflect that on time, then we would be effectively allowing patients to retain fluid to maintain a target weight. And that can, of course, precipitate some cardiovascular events and other issues. And so I do think that, it's one of the, I wouldn't say limitations, but it's just one of the important points of education about using these medications in the dialysis population, is that you need to likely be much more vigilant with dry weight assessments, especially early and when you know that they're titrating the doses, especially for weight loss indications.
This is such an interesting part of the story, so I'm glad that both of you brought it up. Because what you're saying is like there is a world in which we could have hypothesized the opposite, that these medications might reduce MACE, but actually lead to an increase in heart failure hospitalizations if people aren't keeping track of the dry weight. Do we know what effect these medications had on weight, or was that not available in the data?
It is available in the data. We did not specifically look at that. I do know that the study from the group at NYU that published on this prior to our study did note that there was a decrease in BMI in patients treated with GLP-1 receptor agonist use. I think there is data to look into this more, and with future projects that we're working on, we're particularly interested in changes in weight in patients with kidney failure being treated with GLP-1 receptor agonists.
Maybe room for future work. And I guess, another interesting thing that just occurs to me as you're talking is, are these heart failure hospitalizations, these benefits in anuric patients, or is it in the patients who have residual kidney function? Like, what is the mechanism through which these benefits are occurring. Maybe let's shift and just sort of look to the future, like take out your crystal balls for a minute. How do you envision these findings shifting our current guidelines or prescribing patterns for patients receiving dialysis? Like, which patients should we consider GLP-1 RAs for?
I think I can imagine these findings affecting how we manage patients with diabetes with kidney failure. Prior to the phase 3 trials investigating GLP-1 receptor agonists in patients with CKD, the general recommendation was to prioritize GLP-1s for glycemic control after initiating metformin and SGLT2 inhibitors and other anti-glycemic medications. But then with FLOW, we're now prioritizing GLP-1s. And while this isn't the same population, I think we're showing potential benefit in this population of patients with kidney failure, and that this combined with the evidence we've seen in patients with CKD but not on dialysis, that an argument could be made that it may be worth prioritizing GLP-1 receptor agonists for diabetes management, especially if it means less insulin use, which is challenging when patients are receiving dialysis. I think really importantly, a dedicated cardiovascular outcome trial would be crucial in this population. And I think a prospective study looking at safety outcomes would be particularly important as well.
Yeah, I think the call to action, as you noted, I think is a big takeaway that, this is on the heels of this data and some other supportive data in it, both advanced CKD beyond the bounds of FLOW, as well as other analyses of the dialysis data showing merit of benefits with GLP-1 receptor agonists, or in association with benefits, I should say. It's definitely a call to action for cardiovascular outcomes trials in this population for these medications. I will echo what Ben mentioned that, since these medications are safe to use for glycemic control in this population, if there is a strong supportive data set for a closely analogous population, the CKD population, and it's been well studied in other populations which are similarly analogous, such as cardiovascular and heart failure populations. So I would say that it would, to me, at least in my practice, elevate the choice of a GLP receptor agonist higher on my preference list of glycemic control. It is important to note, though, that, however well you emulate a clinical trial with observational data, you just cannot fully capture information as effectively for especially milder safety events that won't lead to a hospitalization and a claim for that. It's also harder to fully capture information about side effects leading to pauses and discontinuation with the same level of granularity that you can get in a clinical trial. I feel like with our data, perhaps if we biased in any direction, it would have been towards the null with regards to that influence, since between GLP-1 receptor agonists and DPP-4 inhibitors, especially, that, in terms of things like GI intolerance, there's perhaps a greater issue with GI intolerance with the GLP-1 receptor agonists versus something like a DPP-4 inhibitor. So you could hypothesize that the discontinuation rates of the GLP-1s likely would have been higher than the DPP-4 inhibitors. We didn't see a very clear difference, but again, looking at prescriptions and claims, we're not going to have the same level of granularity with looking at that in this data set. So, those are important caveats that only a clinical trial really can give you. But, I definitely support, at least taking its current indication for diabetes and sort of elevating it a little bit in its priority for the dialysis population.
Des, thanks so much. That's really helpful. I was also thinking about the population that's being considered for kidney transplant and is overweight. And often diabetes and overweight go hand in hand. I know this is not like the explicit focus of your study, but can you offer any insights to guide us in terms of, if we've got a patient who's struggling to qualify for transplant and lose weight, should we be thinking about these agents as opposed to bariatric surgery? Where does GLP-1 stand in the list of options that we have to get patients qualified for a transplant?
I think they represent a pretty attractive option for weight management for patients trying to lose weight to qualify for a transplant. That said, they were left out of the clinical trials that looked into using these for management of obesity. But I think the more we explore GLP-1 receptor agonist use in patients requiring dialysis, the more comfortable I think we can feel that this is a reasonable option. And I think surgery is a pretty significant, can have a lot of significant effects for patients. So potentially medications could be a more attractive route for them. And I think beyond this, it's a particular research interest of mine and hoping to explore this more with some prospective studies in my K grant. So I think this is an area that we need more research in, and excited to keep looking into it as I think it's an exciting option to manage weight for patients.
And there are some ongoing studies specifically looking at that use case for GLP-1 receptor agonists. And so I hopefully we'll have some, at least some early data with regards to that, which I do think is an exciting use case for these medications, like, as you mentioned, specifically using them for their weight loss indication in that population, which oftentimes can get excluded from transplant candidacy solely due to BMI, which this would be an exciting way of avoiding surgery, but still allowing them to become eligible for the transplant and maybe even improve their cardiovascular risk profile in the process.
Mm-hmm. Well, this is really exciting. This has been such a great conversation. It's given me lots of little nuggets, if you will, to chew on in terms of thinking about how to use these agents in my practice, hopefully for our listeners as well. Just again, congratulations on a really nice study, and thank you again for joining us.
Thanks so much for having us.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.